thanks so much, Dr. Merbat and Dr. Layla Sharif, for inviting me to share our unique experience with our unique cohort of Gaucher disease patients. I chose the title of this talk because NGD, or neuronopathic Gaucher disease, represents up to 70% of our Egyptian cohort. Now, for those who haven't been to our Cairo University Pediatric Hospital, this is one of 3 buildings, and this is the biggest. And on the 2nd floor resides the Hematology clinic, where we give our Gaucher disease patients their ART every 2 weeks, a dose of 60 IU per kg. We have around 130 patients. About 40 patients are receiving home treatment, and the rest, they are divided into 2 groups, and they come every 2 weeks for their dosing. I'm going to go very briefly through the pathophysiology and the prevalence of Gaucher disease, and then I will highlight in details the clinical phenotype, as it's one of the main things that leads to the diagnosis, and afterwards I'm just going to give the glimpse on treatments. So what? I would like to thank very much Dr. Mohammed Bashir, because he gave a very informative talk on the lysosome, highlighting its importance because it plays a very important role in all the lysosomal storages. Now, Gaucher disease is the most prevalent autosomal recessive lysosomal disorder, comprising 48% of single nucleotides in Egypt. And we actually published this study, and it comes second after MPS or mucopolysaccharidosis. And it's due to the mutation of the GBA gene encoding the acid beta-glucosidase. So, what happens because of this gene? The thing is, the monocytes are produced in the bone marrow, and they mature into macrophages. But in other organs, whether the lung, whether the lung or the Kupffer cells in the liver, the bone or the spleen, and they lead to subsequent involvement and hepatosplenomegaly or infiltration of the bone marrow by cytopenia, pulmonary involvement in the form of recurrent lung infections or wheezy chest, and osteopenia, bone fractures, or avascular necrosis in the bone. How about the CNS? Actually, it remains still a puzzle. We don't know what's going on. There has been previous reports that it's due to deposition of cytotoxic agents or due to perivascular infiltration of the glial cells and the macrophages in the CNS, but actually recent reports in the knockout mouse showed that Gaucher disease in the CNS is a neuronal disorder with an additional role for astrocytes, and Gaucher cells only play a minor role. Now, classically, and this is very important to highlight that it's only classically, Gaucher disease has 3 phenotypes, depending on the absence or presence and severity of neurological signs. The non-neuronopathic or classically type 1 Gaucher disease, and the neuronopathic types 2 and 3. But the demarcation between the neuropathic variants is imprecise, and it's more accurate to consider such phenotypes as continuum of disease, especially with the recent association of type 1 with Parkinson's disease, and the GBA gene is the most important predisposing factor for Parkinson's disease. The prevalence of type 1 GD varies from 1 to 40,000 up to 60,000, and in the Ashkenazi Jewish population, it comprises 1 in 180, because they are a close community. Regarding the neuropathic forms, they are reported in less than 1 per 100,000 live births. And they comprise 6% of Gaucher disease patients, with type 3 representing 5% and type 2 1%. Now, it's very important to highlight that type 3 has a very high prevalence in the eastern populations, especially the far eastern, ranging from 30% in Japan up to 55.2% in China, with a high prevalence in Egypt, up to 70% in some centers. Now, regarding the genotype-phenotype correlation, there are more than 400 reported mutations, with the M307 mutation the commonest in the Ashkenazi Jews and in type 1 Gaucher disease patients, And L4-4P is pan-ethnic. The homozygosity for L4-4P is most likely associated with neuronopathic Gaucher disease, with a very wide phenotypic spectrum worldwide, including our unique Egyptian GD3 cohort. And that's another very important publication that varied in the perception of Gaucher disease type 3 worldwide. Some authors divided Gaucher disease into the type 3, of course, into 3 types, A and B and C, but this is too artificial and too heterogeneous to accommodate all the phenotype. Regarding the homozygous D409H, it has some phenotype-genotype correlation, being associated with cardiac calcifications, corneal opacities, and hydrocephalus. And again, that highlights the link between lysosomal storage disorders because we find that in the MPS patients. However, cardiac calcification have been recently reported in other genotypes, including our cohort with homozygous L4-4P. Now, there are other mutations in other ethnic groups, as the F2131 allele, common in the Japanese cohort as well as the Korean one. Now, we will expand more on our phenotype of GD3, highlighting the Egyptian GD3 phenotype. Now, it's very important to know that GD3 patients not only have neurological manifestations, but also non-neurological manifestations. The neurological manifestations would include psychomotor delay, supranuclear gaze palsy, convergent squint, bulbar symptoms in the form of dysphagia, dysarthria, stridor, cognitive impairment of variable degree. And I'm highlighting these 3 phenotypic variabilities because they are unique to our cohort, whether regarding the prevalence or their presence. And that would be the seizures, the behavioral abnormalities, and sudden unexpected death of epilepsy, a very important phenomenon that we reported in our cohort, and it's present in other cohorts. Yet they have been unaware of it, and it's been underdiagnosed. Regarding the non-neurological, it does not only involve the hepatosplenomegaly and the bicytopenia, but also bone involvement, lung involvement, kyphoscoliosis, and its etiology is still unknown. And it's very important to look for lymphadenopathy or lymph node infiltration with Gaucher cells, as well as infiltrations of the eye, which can be quite serious, even the teeth and cardiac. Now, there is considerable intrafamilial heterogeneity, and that's a family of 3 siblings, where you will find that this girl, which is the eldest, is moderately involved. However, the second girl is much more severely involved with seizures, and this is the youngest, and he is the less involved. However, these 2 girls have had splenectomy done, and it's very important here to highlight that splenectomy is contraindicated in type 3 because it worsens the condition, the bone and the neurological manifestations. Now, as you can see here, this slide is very important. It represents the wide phenotype spectrum of our Egyptian cohort, where you find here patients that have been only diagnosed with genotype, and this boy is currently 17 years old, and yet he does not even have the hallmark of type 3 Gaucher disease, which is the supranuclear gaze palsy. And on the other end of the spectrum, you will find this young man who is currently 19 years old with severe convergent squint, uncontrolled seizures, and kyphoscoliosis. Now, regarding the visceral involvement, there is also a very wide phenotypic spectrum. You will find this girl here with only mild hepatosplenomegaly, and this boy with huge organomegaly and a platelet count of less than 10,000, which we usually don't encounter in Gaucher patients. Usually the platelet count is around 60 to 80. Regarding the visceral involvement, there is also a very wide phenotype. You will see here that this boy has severe involvement of his liver and spleen, together with lymph node infiltration with Gaucher cells that you can see here in his CT, as compared to this girl. Now, in the middle, you will find patients with mild to moderate neurological involvement, but more severe visceral involvement. This girl currently has kyphoscoliosis as well as lymph node infiltration with Gaucher cells, and both had lung involvement, which they have outgrown. Now, it's very important to note that patients can present as early as during the first 6 months of life and as late as adulthood. However, the majority would present in childhood with 47% before 2 years of age. The typical clinical scenario that we usually see is an infant presenting with abdominal enlargement, anemia with or without thrombocytopenia, with associated mild to moderate motor delay and sometimes bulbar symptoms. The bulbar symptoms are quite prevalent in our cohort, representing 37%, are due to cranial nerve involvement and include stridor, swallowing difficulties, and speech problems. Stridor is usually noted among younger infants in the first 2 years of life. And speech problems can range from delay in speech to dysarthria and inability to talk. Now, the eye signs are the hallmark of Gaucher disease. Same as in Niemann-Pick, especially Niemann-Pick type C. They would include the supranuclear gaze palsy, usually to horizontal gaze, but can involve the vertical gaze, contrary to the Niemann-Pick. And convergent squint is quite high, and it's not usually, as previously thought, associated with the type 2, but with the type 3 Gaucher disease, usually the severe phenotype. And in our cohort, it comprises 22%. It's evaluated in a very simple way, and it's very important because it's the hallmark of the disease. And that would be by fast eye movement and observing the patient's ability to look to the extreme right or left and the extreme up or down. Assessing head movement is very important because these patients usually compensate by head thrusting, like this, looking to the side. The cognitive profile is quite variable, varying from 85, an IQ of 85 assessed by the Whistler scale, plus or minus 13, up to 68, that would be severe involvement, plus or minus 15. Seizures are quite prevalent in our cohort, reaching up to 31%. But contrary to the reports in the literature, they can be focal secondary generalization, generalized complex fracture, not just myoclonic as reported in the literature. Now, this phenomena is quite important because we reported it in about 20 of our patients, and that would be sudden unexplained death in epilepsy. And how would that present? The patient would be doing more or less well, having a normal EEG, and then all of a sudden would develop a seizure. And it is the first and the last seizure, and afterwards these patients would die. Also, behavior abnormalities and problems, they include irritability, antisocial behavior, anger, and aggressivity. Now, regarding the non-neurological manifestations, as we previously mentioned, but very briefly, it does not only include the hepatosplenomegaly, anemia, and thrombocytopenia, as we all think, but lymphadenopathy, and that would be due to infiltration of the lymph nodes with Gaucher cells, usually mesenteric lymphadenopathy, and it can be quite serious, presenting with protein-losing enteropathy. We have to look for it to diagnose it before symptomatizing. But any other groups of lymph nodes can be involved, whether mediastinal, inguinal, cervical, or any group. Regarding pulmonary complications, they not only include the recurrent chest infections and Magy's chest, but also radiological changes, mainly interstitial lung disease reported in up to 70% of patients. The bone complications would vary from bony aches and osteopenia up to avascular reticulosis and avascular necrosis of the femur and fractures. Very interestingly, and it's only reported in our cohort, we had dental infiltration with Gaucher cells. Also, there are infiltrates of the eye up to the retina, causing impaired vision. Kyphoscoliosis is of unknown etiology, and one of the things that have to be really looked into more details. Now, diagnosis. This is very important. A diagnosis of Gaucher disease is based on clinical signs and symptoms, family history, and confirmed by laboratory tests. Bone marrow aspirate is non-specific. It's not diagnostic, and many patients are missed because of that. Once diagnosis is suspected, beta-glucose reductase activity is measured. This is because low enzymatic activity is the gold standard for the diagnosis of Gaucher. The normal range would vary from 1 to 5 micromole per kg per protein per hour. Genotyping is then conducted by direct DNA sequencing for common mutations. And in our cohort, that would be the homozygous L4-4P, the homozygous B409H, or any heterozygosity of these mutations. The diagnosis, however, is based on neurological abnormalities, plus or minus genotype. If we have a patient like you saw in the picture previously, with a homozygous L4-4P, yet having no neurological manifestations, including the supranuclear Days palsy, this patient is regarded as type 1 until he develops any neurological manifestations. Gaucher disease may also be diagnosed in asymptomatic individuals. It's very important to do that in order to diagnose them early and start early ERT. Serum chitotriosidase is an important prognostic marker amongst others, but this is the only one available in Egypt. Now, regarding treatment, enzyme replacement therapy is still the gold standard of therapy. The first enzyme was Cerezyme, by now it's Sanofi enzyme. It's a recombinant glycosylceramide enzyme that has marked beneficial effect on visceral and hematological disease inside frame. But its effect on existing neurological signs and their progression is a subject of great debate. Yet we reported in our cohort improvement in the bulbar as well as the behavior abnormalities, probably because these are at the level of the brainstem, which is not surrounded by a blood-brain barrier. Now, there are other enzyme replacement therapy that have been FDA approved, the VPREV or the VP-glycerase alpha and the teleglycerase alpha. Now, there's substrate reduction therapy, and that's important as it reduces the glucose riboside formation. Yet, it's usually better to use the substrate reduction together with the ERT or the enzyme replacement therapy, especially in non-neurological manifestations as lymph node and pulmonary involvement. Regarding the pharmacological chaperones, these are small molecules that increase residual protein function by stabilizing misfolded mutant proteins, preventing endoplasmic reticulum-associated degradation in proteasomes and allowing trafficking to lysosomes. And Proxil is one of these, and it's been reported to be of benefit. BMT was used before the ERT era, and currently its role is minimal. Gene therapy actually is currently on its way. Now, there's systemic supportive and adjunctive management options. Most importantly would be the blood transfusion, the iron supplementation, especially before starting ERT and in decompensated patients. It can be anticonvulsant, calcium supplementation, or bisphosphonates in patients with severe bone involvement and severe osteopenia. In conclusion, Egyptian type 3 GD patients have a phenotype and clinical outcome that are very different from those observed in other populations. So, it's likely that modifier gene variants are common in this population. Now, this is a very important slide for me because I always believe I owe my patients so much. This is a patient that is currently 12 years old and has been through many struggles. And these are some of our other type 3 patients who are doing well. And this is our national Gaucher disease Egyptian US group. We're celebrating 15 years of Hope Project, and this is our international group. And thanks for Sanofi, Shire, Hope Project, and MOH for providing ERT to our patients.